Hello and good evening, everybody. I'm Dr. Gyan, and on behalf of Cornea Society of India, welcome you all to today's Kera Grand Round, the first one this season. For those who are new here, Kera Grand Round has been CSI's highly successful teaching learning webinars, and now we have reached the fourth season. This evening, we have a very interesting and I would say challenging topic, keratoprosthesis, and our esteemed speakers will be sharing their journey in this surgery, which is most important, sharing your journey. Dr. Paras and her team has worked very hard in bringing this together. Very much looking forward to it. Dr. Paras, the show is yours.
Uh, Thank you, Dr. Gyan. Good evening to everyone and welcome you all to this Kera Grand Rounds. At the outset, I would like to say that this is a difficult topic, but it's going to be very interesting as we have esteemed faculties who have tremendous experience in this field. And for this, we have today 3 talks and 3 cases to be presented. Uh, Before we move on to that, I would like to just introduce the faculties for this uh, session. We have Dr. J.K. Reddy, who is the head of Department of Cornea and Refractive Surgery at Sankara Eye Care Center, Coimbatore. He heads Research and Development Wing at Sankara Eye Care Institute. And very interesting part is he has invented and patented many ophthalmic devices. I would not go into the list of that, as I mean, probably the time would be over. And the other part is like pertaining to this particular seminar, recently he has invented, made modifications into Oro Kepro model, which is called as Oro Kepro S. And probably he would be talking to us on that. Welcome, sir. Our next faculty is Dr. Pallavi Joshi, Senior Consultant Cornea, Ocular Surface and Refractive Surgery at SEI Bangalore. And she has more than 15 years of experience in subspecialty. And she's more interested in ocular surface disorders and pediatric keratoplasty. Welcome, Pallavi. The third faculty is Dr. Shweta Agarwal. Currently, she leads the ocular surface clinic at Shankarnetralaya, Chennai, and she's a core member of Ocular Allergy Task Force, as well as she is an associate editor for IJO. She would be a moderator as well for today's session. For the panelists, we have Dr. Radhika Tandon, who is a head of chief of RP Center, one of our Apex Institute of Ophthalmology. We are very lucky to have her here. We have Dr. Bhaskar Srinivasan, who is currently part of Code Eye Care. He's one of the lead into Code Eye Care Center. And we all know that he's a great teacher. And the third person is Dr. Balekar. So he is working at Maharashtra, Shirur, and especially he is focusing on rural Maharashtra. That is also something challenging. He is very much interested into ocular surface diseases and keratoprosthesis. So we have great panelists for this session. It's a combination of private, institutional, and rural care, I mean, persons. So we will have different perspectives. For moderating this session, we have Dr. Shweta Agarwal as a chief moderator, and we have Dr. Vandana Sundaram, who is a part of Sankara Eye Care at Coimbatore. She's a cornea and ocular surface consultant, and she would be assisting Dr. Shweta Agarwal for moderating this session. So welcome all of you, and I would hand over to Dr. Shweta Agarwal. Shweta, it is all yours.
Thank you so much, Dr. Paras and Dr. Nyan. It's KeraRounds is really a beautiful initiative, and we all have been enjoying. So I hope today's session turns out to be as fruitful as the past ones, or a slightly better version. So we start the session now. We have the first speaker, Dr. Pallavi, with us. Dr. Pallavi, would you like to share your slides?
Yeah, sure. Yeah, I will share. Is it visible?
Yes, Dr. Pallavi. And it's in the correct forms. So please go ahead.
Thank you. So good evening, everybody. At the outset, I would like to thank the Cornea Society of India for having given me this opportunity to be amongst you all. So I would like to talk about keratoprosthesis, our real world experience. So as we all know that corneal transplant is highly successful in restoring sight. However, regrafts actually account for second most common indication for PK. And severely diseased eyes are more prone for graft rejections and failure than otherwise. So, did I close my thing? Okay.
Just
No,
carry on.
everything is visible.
It's visible?
No, you
Yeah,
just
what
closed
you
it.
did. Yeah, go for normal.
Yeah,
Yeah.
I'm just... yeah. Just,
Dr. Palvi, you have to go for the slideshow.
yeah, I'm starting. Mm. It's not happening. Yes, I will restart. There is some issue.
Shabina, can you assist her?
Just give me a minute.
This is Zoom.
Oh, no, I think this got closed. So I'm just trying to.
Yeah, you closed it. You closed it by pressing the red button. So you have to open PowerPoint, then again share.
Is it visible, sir?
No,
ma'am.
no.
You'll have to
You
share
get
your
screen.
presentation.
Give me a
Now,
minute.
the escape button, then go to the window, then go.
I just give me a minute's time, sir.
Now open the PowerPoint again.
Yeah, just a minute, sir. I will just do it. I'll open my PowerPoint. I'm really sorry. I think there was some issue with my this. Mm. Yeah. Now it's visible, sir?
Yes, yes.
Yes, ma'am.
Now you go for full screen.
Slideshow.
Yes. Yeah. So I think now. So as I
Yes.
was talking, so not all high-risk grafts are actually ideal for transplants in the first place. So keratoprosthesis seem to offer visual rehabilitation where corneal transplants have extreme poor prognosis. So what is keratoprosthesis? It's a surgical procedure where severely damaged or diseased cornea is replaced with an artificial cornea to restore useful vision. So we can broadly classify them as permanent or temporary, or as integrated or non-integrated. And in the most practical sense, we classify keratoprosthesis, those we use on the wet surfaces or on the dry ocular surface. So our journey at Shankara Eye Hospital, Bangalore, with respect to keratoprosthesis started with actually a Rotary collaboration in 2013, wherein we were provided with a grant to begin with the Keratoprosthesis and Research Center. But to just tell you all, from 2013 till 2016, even if we had grant, it took a lot of groundwork to do, and also to actually find the right way with instruments, materials, and obviously the right choice of patient. I've been very lucky actually to have Dr. Vinay Pillai as my mentor during this all past 10 years, through whose little teaching and as a tutelage I've been able to go through with especially the modified keratoprosthesis, that is the OKP. So our experience with keratoprosthesis has been with all the types of K-pros. So the type 1 K-pros, around 30 till date we have done, a couple of Boston type 2, and a few LVP, and OKP around 15 are there, of which 13 have completed till date. So as we all know, the type 1 Bosto basically was the one which was proposed by Professor Charles Doman, which is having actually a collar button-shaped device, a central plate and a back plate. This is usually mixed along with the cornea and gives a visual field of 60 degrees. So in our series, when we have done the type 1, majority of our cases are the Oro K-Pro. A couple of them are the Boston. So in this, our series of patients whom we have used this K-Pros are all multiple graft failures who are one-eyed, and few of them were chemical injury. Of this 2 only have been pediatric cases. One has been the one after multiple transplants and a glaucoma. And around 26 patients have been aphakic capros. Only 4 who were already having a pseudophakic status. With this, 4 of them, we have also done an AGV implant. So our outcome of 5-year anatomical success with respect to the type 1 K-Pro has been around 95%. And the functional success has been of more than 624 in nearly 30% of them. 60% of them have a vision of about 660 or more. So these are a few cases of our type 1 K-Pros in which we have done this. And as you can see, this is around, different various indications for which we have used them. This are our long-term, more than 8 years follow-up. As you can see, as the time of transplant and the K-Pro happens, you can see that those holes are closed up, but the surface is well integrated, nicely vascularized, and anatomically holding on, and also giving good amount of functional vision. However, having said this, it doesn't mean that we didn't have challenges. In our cases, we have had perioptical melts, especially from 2013 to around 2000, probably 18-19, the Oro K-Pro model was a little different, where we had a lot of challenges with perioptic melts and infections. However, that has come down from the past 5 years. The retroprosthetic membrane, which even according to literature shows to be the maximum cause of problems in these K-Pros, is 40%. We had a few of cases in which raised IOP were there, a few challenges with compliances. So just to show you a few complications, this is like the patient in whom we have been having RPM. We usually deal with them when they are very thin by doing a yak cap, or sometimes we have to go inside and get the membranectomy done. So some other cases had melts and leaks where we have actually also need to use a kind of a scrub, okay, or we have been closing it up with conjunctiva. Infections have been there. Also, we have had a couple of cases of endophthalmitis. One, this was a staphylococcal infection in whom we intervened, did a via surgery, and patient is maintaining good integrated K-Pro. However, recurrent RPM occurs and we do tend to release it and he gets a good vision. Now coming to the dry and hostile surface, we all know we can't use the Oro K-Pro because they cannot sustain, because we're using a cornea there and there is no epithelial or a sealant aspect in that. So we use the Boston type 2 or the MOKP and a few of LVP K-Pros in this kind of cases. So Boston type 1 and type 2, the difference is there is a 2 millimeter anterior hub, which is designed to get out through the lid. And this gives comparatively a little better visual field of 40 degrees. So in our series, we have done till now 2 Boston K-Pros. One was a long-standing chemical injury one-night patient, and the other was a case of ocular cicatrizing pemphigoid. This patient now, one of them has finished more than 2 years. The other one has finished around 2 months. And the person with 2 years is maintaining a good 6/9 vision till date. We have done a couple of LVP K-Pro. However, this patient has been having repeated RPMs, but she is able to manage till around 2 to 3 years. Later, she developed a chronic RD and has been not having a very great vision. Coming to OKP, as we all know, it is a tooth in eye procedure, which was actually pioneered by Strampolini and it was modified by Falsellini. It's known to have the best long-term visual as well as the retention outcomes. What is nice about this K-Pro is it is a biological peculiarity of a recall. We are using a tooth and we are using the gingiva. So this is one of those where there's a true epithelial sealant, and that's where the chances of the perioptic issues or the protrusion and other things are limited in this case. So where do we normally do this modified OKP are the very severely dry hostile eyes. Most of them are bilateral involvement and you always operate in one eye, whether it is the MOKP or any type of K-Pro. You do it in 3 stages, stage 1A, stage 1B plus C, and in the last stage is a stage 2. Where do we do not do? Usually MOKP we don't do in children less than 17 years because the tooth resorption is very fast. In poor compliant patients who are very bothered about their cosmesis, glaucoma, and retinal disorders. So just to show the whole glimpse of MOKP, because there is so much of shortage of time, I will just show that the first stage is where we prepare the eye, make it a unicameral eye, remove the iris, remove the lens, and also place back if the cornea is good and healthy. If it is not, then we tend to replace it with a donor cornea. In our series, the first 5 cases, we have actually been doing minimal antivitrectomy, but in the remaining we have started doing a core vitrectomy with an endo laser as a prophylactic. And this has been kind of a thing which has helped us to take care of the intermittent issues with the retinal aspects. So once this stage is done, then we go ahead with the tooth procurement, which with the help of a dentist, we are taking a monoradical tooth, usually the canine, and then we fashion it in a kind of a lamellae and centrally create a hole with using the burr, and then place the optical cylinder with an bone cement. And at the same sitting, we take the mucosa from the cheek. So once that is done, the eye is ready for the last stage. Usually the ola is kept in the contralateral subcutaneous space for the biointegration. After 2.5 to 3 months, we open up the mucosa, make a central opening. Usually it depends on what size we have used, around like 3.8, 3.9. And then the ola, which is now nicely formed, is fixed to the surface. Then we bring it out through the mucosa and deliver the cylinder. This is how the process is done. However, this takes over a period of nearly 6 to 9 months to finish one procedure of the patient. So in our cases, 14 cases, we have 13 cases. Majority of these were Steven Johnson. One of our case was an aluminum blast injury case. And our 5-year success rate of our MOKP patients have been 92.8%. And functional outcome of more than actually 20 by 80 is around 41%. And around 20 by 23 is around 83%. But challenges have been also there, especially with the healthy tooth, mucosa, and psychological counseling, and also outcome variability. We have had cases, this is our clinical outcomes, a few of them just to show to you all. So, which we are having here. Now, coming to the complications, the literature shows this kind of like endophthalmitis, retinal detachments, then cylindrical this expulsion, and even glaucoma. In our series, our complications were more related to mucosa, the ola, glaucoma in 2 patients, in whom one of them we had to go ahead and do an AGV later after doing the whole of the procedure, and one in the second stage only we have placed an AGV. We have not had any retroprosthetic membrane in our patients, no retinal issues. One case had an extrusion. So just to show that, yes, it's not a cakewalk. Mucosal nightmares are there, like this necrosis, but managing with lot of lubricants, ointments, we tend to sometimes be lucky and be able to get back the mucosa, but sometimes it is not. So in such cases, we actually do the last stage through the lid. And in our series, we have 2 cases which we have done through the lid. We can also have a mucosal hypertrophy. This is a patient who was the aluminum blast injury, also was a kidney eater. He was from Bihar, and this was our COVID case wherein he could not come when he had this kind of leakage. As you can see here, he started having the resorption and we had a lost battery. So we had no option, but when he came to us, it had already extruded. A few of late ola exposures we have had where we have managed with the small rotational mucosal grafts. And this was immediate post procedure of stage 1C, and here stage 2, where we went ahead and did a rotational graft and along with the tarsal plate, and patient is doing fine. So we also have cases in which we have, the tooth resorption which occurs. This tooth resorption is an innate thing to how the tooth quality is, the patient's own systemic condition and the tooth condition. So this is a very unfortunate case. Patient actually is maintaining a 6/6 vision, and she's not ready for us to do an K-Pro exchange, and we are trying to counsel her, but you can see that superiorly there is a loss of the superior rim, whereas everywhere else the ola is nicely intact with the processes in situ. So this is our longest follow case. He was around 19 years old. We operated him 2018, we finished actually, and he had come this April, and he still maintains a 6/9 with a corrected 6/6 vision, and he's now around 26, 27-year-old kid. Having said this, what I want to tell is our learning through the keratoprosthesis journey is that complications are a norm than rarity in it. I prefer to put them as challenges, and knowing why it occurred, what is the challenge, and how to tackle it are the cornerstones for approaching for better outcomes. Keratoprosthesis is actually a hope for despair. It's a teamwork of doctors and patient together. And the real journey, according to me, begins only after the surgery is done. So with this, this is our first patient, and I would thank my mentor, Dr. Vinay Pillai sir, for really handholding us all this while and teaching us the best that I could ever get. This is our team of doctor, dentist, and the anesthetist. And I would actually express my gratitude to my alma mater. I have done from Arvind Eye Hospital, where the first thing of character processes started with the Oro K-Pro. My mentor, Dr. Srinivas sir and Gina Mascarens, were the ones who actually instigated that in kind of thing which made me take up character processes. My acknowledgement to my patients, my hospital, Shankarai Hospital, Bangalore, Vinay sir, our dentist, our Department of Anesthesia and Retina and Glaucoma, and also my fellows. So thank you very much.
That was really brilliant, Dr. Pallavi, and kudos to you for the brilliant work that you've been doing. We all know that not just operating, but managing and taking care of keratoprosthesis patients is really difficult. And I can, I have seen witnessed the struggle and the efforts that you've put in all these years. And yes, you had the best man to handhold you. That's Dr. Vinay. I think he is one of the best mentors to have. So in this journey, what is one lesson that you would say is something that you would really want the new beginners or the people who have joined us in this KPRO session, that is one thing that you learned in your journey is the most precious learning?
My precious journey lesson has been that never push for a case for a surgery. I always have a very, 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 a very high threshold to convert any case for a keratoprosthesis. I've always seen that we try everything right from correcting the lid, giving them scleral lenses, managing them with MSGT, and only when nothing works and patient is really ready for it, I think we should only get it done then. So that is my learning, that we should know when not to operate, which is the most important, according to me.
I think brilliant, Dr. Palvi. I think all of us agree. We have Dr. Radhika with us. Dr. Radhika, would you like to add something or share some pearls? Dr. Radhika, you're on mute. You will have to unmute yourself.
Sorry. Yeah. So, good evening, everybody. Firstly, I really appreciate and congratulate Dr. Pallavi and her institute as well as her mentors for having, taken the struggle and having nicely recorded the cases and achieved very good results. Because, to look at it a different way, that there are these total 20, 25 patients whom you have given, a new lease of life. And as Pallavi has said, she has tried every other measure first. And it was only the ones who really needed this extra extreme step, they have undergone it. And then they have had what I would say very good success. The other thing is that I feel that I will not encourage many people to start just operating right, left, and center. This today's platform should be more to sensitize people to know that this is an option available at certain centers, and more for case selection and proper referral. So don't refer cases across big long distances where the person then ends up and then is told no, it's not possible. So there should be some kind of a discussion with the surgeon before, should we refer the case, etc. So these are the two things I'll say. Try every measure possible, and having say 3/60, 4/60 vision for 20, 30 years versus getting 6/6, 6/9 vision for a shorter time and then losing it. So that's the thing that you have to understand and talk over with the patient. And if I'm not mistaken, a lot of these patients tend to be young, as Pallavi nicely showed, 18, 19. So a lot of decision making and joint discussion is required. So a lot of chair time, and that's it basically. So it's a good surgery. Requires a huge commitment and very very high level expertise.
Yeah, thank you, Dr. Radhika. I think very well said that it's extremely important that people understand, and Pallavi has very beautifully highlighted that it is not just the success, but each keratoprosthesis comes with its package of complications, and the pre-operative planning and the post-operative follow-up are the two most important keys when we are managing these patients. It's an umbilical cord which never gets cut. You are married to them for the rest of your life, and there is nothing called as divorce. You cannot divorce them. So moving on, I think we'll move
If
to
I
the
could,
next speaker. Yeah, Dr. Bhaskar, please. Sure.
yeah. So the important thing is keratoprosthesis is an option for end stage disease, but it's important to know there are diseases like SJS, chemical injuries, where if you manage them well in the acute stage, you actually prevent them from reaching or requiring a keratoprosthesis. So the emphasis also has to be on, we are trying everything, but the management in the acute phase, whether it is SJS or chemical injury, needs to be more appropriate. So the need for us to do keratoprosthesis is much lesser. One. Second, you have to choose your cases judiciously. You have to, like Pallavi said, you would probably want to keep that as the last option. You exhaust everything else before you do a keratoprosthesis. But at the same time, if it's a bilaterally blind patient and you're not really sure, even in desperate situations, provided the patient understands what we are fighting for, even that 1 by 60 or 2 by 60 vision that you can give them makes a huge difference as far as their quality of life is concerned. So have an idea that there are certain patients where we can do keratoprosthesis. Be in touch with surgeons who are doing it on a regular basis. If you want to start doing it, make sure that you have a mentor, make sure that you go and see. And it's not just seeing the surgery, it's seeing the patient at all stages of the surgery, pre-op, intra-op and post-op, which gives you a holistic idea. And you also have a mentor like Pallavi had, Dr. Vinay, to kind of guide her at times when there is a bit of a problem that you face. And you will face problems in keratoprosthesis. It's not that you do the surgery and everything ends there. The story begins there.
Yeah, just one sentence, Shweta, can I say?
Sure, yeah, please, Papal.
Yeah, so I would just say that who sir wants to do K-Pro, that every K-Pro you do is a high risk eye forever. I mean, it is never going to be like, it is settled now and, you can relax and you can call patient after many, many months. So it's an high risk eye forever and you got to respect that. And congratulations, Dr. Pallavi, because doing K-Pro is not just a surgery. I think it's a lifelong commitment for surgeon, for the team, for the patient, everybody. So just one sentence, if someone wants to start the K-Pro, I think that commitment is needed from all the sides, from as a team, not just the surgeon or not just the patient or the team. You need to have the team and you need to have the commitment.
Absolutely true, Dr. Swapnil, and some great points by Dr. Bhaskar there. I think we'll move ahead with the next speaker, Dr. J.K. Reddy. He's ready with his new design to share with all of us. Over to you, Dr. Reddy.
Is it visible?
Yes, sir.
Okay. This new design, why should we do it? That's what we are just going that. And so we have been doing this different type of cattle process for 2 decades. So we tried different models, like instead of cornea, because sclera will never get infected by bacteria, very, very unusual. So we thought replace the cornea with the sclera, it should work well. So we replaced the cornea with the scleral collar, skirt, and tried it few cases. Many cases we tried with the sclera, and we tried modified Pintucci with the Dacron skirt, some cases, and we tried titanium. This is a modified Russian model, Russian kept process model. We modified it. So we tried these cases. It's like that, this journey is going, and then real Boston kept process, or kept all we tried. But we had our own set of success, one set of complications, all complications, you name it, whatever is there in the book or internet, we saw. So we have ups and downs, we have complications, we stop it. Then we saw a good patient, we do it more. When the patient comes, some good patient. Then again, we have some complications, we stop it. So we learned a lot of lessons over a period of 20 years. So keeping that all, we come with a newer designs depending upon what probably are the cause. We have a list of complications going on. And what is the probable cause for that? We are analyzing in each and every case. So delivering that, we design new model called R Model S. So all car looks the same way this also looks big. It's not in the looks. This is the design, not how it works. The designing is, it may look same, but the working will be completely different depending upon the design. So it is complete, it's a different one. It is not the Boston, it's not the RK Pro. But what is the main difference? Here, what we learned, The 5 mm front plate, which are giving standard, we thought that's not good. So we went for 6. The Kuresh asked me, why 6? Why not 7? 7 may be better, but we don't want to jump all of a sudden. That becomes more hypothetical. So we thought 6 is a good. So we went for a front plate 6, and the optical cylinder we increased to 3.5. So you put a 3 mm sponge and you put a 3.5 into that, you will have very snug fit. And we completely modified the back plate. So we removed the rigid, thick back plate from the Boston or the other model, PMMA or titanium model. We made a flexible PMMA, very new design, 7 mm black plate. It's not very rigid, it's thin and it's flexible. And it's got a lot of openings for nutrition of the cornea. And the titanium ring also is a new one. It's a little bit thick, a little bit hard to push, but it locks very well. So this how it's titanium we tested in the laboratory. After doing that, so we modified the pushing mechanism. Instead of giving a plastic, we modified that like a marker. This one for a RK marker. You use that type of thing that's locking very well. You can see through that, and you can see. Then the main thing is the gap. The space between, we reduce the tolerance. Now at the edge of 6 mm, the gap is only 0.43. That means 430 microns is the gap. So it actually snugs into the cornea. It fits very tightly into the cornea, and in the cut, in the central optic segment, it is a 0.49. That comes around 490 microns. That's how then most of the donor corneas are without epithelium we found in our studies. So this we tested in the laboratory, we fixed them, put in artificial chamber, put the pressure up to 300 millimeters of mercury, we put it and saw whether anything will loosen. And after doing many studies, we came to a commercial production. This how this procedure is done. For example, this is a case. This is a 3 mm sponge, the 3.5. This is very delicate backplate. We should take care of it more than the Boston cable. Boston cable, you can do it whatever you want. Here you have to gently manipulate it. So only thing is the titanium lock. The lock, when you are locking, you should be a little bit careful and lock it properly because the tolerance are very low here. The tolerance are very low. Manufacture tolerance are very low, and designing tolerance also very low. As I said, we are having 0.43 only at the periphery. So we need a iridium cornea, little bit tight titanium locking. So what we learned is titanium locking better you do on a Teflon block, not on the one which you are giving in the RO lab. You take off everything. Don't do like what I did it, what we learn now. Take off all the things and put on a Teflon block which you cut for the donor. Then do it. The locking is much, much better. So this is a patient with multiple grafts and rejected and all the problems, no iris, no cornea. And actually we did a RD valve also for him because intractable glaucoma. This is a, process, large process, donor cornea. And this is how it looks on the table. And this is the post-operative appearance of the patient after a few months. And sutures are all becoming loose. We are removing them. Any suture we have to remove. Most of sutures we remove 1.5 year. No contact lens because already we are having 6.5. Very few months, 2 to 3 months, we are putting contact lens then removing because optic 6.6 millimeters it's covering very well. And if the nice OCT is showing nice coverage and epithelium trying to migrate. Another small thing is the edge of the optic also we are given 0.21 mm. Unlike the Boston K-Pro is 0.18 mm, we are given a little bit thick because Boston K-Pro often we see chipping of the edges after some time. So this is the Stevens-Jones syndrome. We have only one process we designed for all the cases, both for dry surface and wet surface. This is the Stevens-Jones syndrome case. So we just remove all conjunctiva, whatever, even if anything is there, we remove everything from lid to lid. That's what we initially we are a little conservative. Now we are removing and ECCE, and we generally we put a 0 power IOL, neutral IOL. Then we put the process and we put the buccal mucous membrane and make a opening in the center, small opening. Generally, it will close down to release it, and we'll put a conformer and we close that, and we do a torsography. And conformer we remove after 3 weeks, and torsography removal. Then after 2 months, we release a little bit torsography. We don't remove it heads to heads. We remove a little bit torsography and put a pediatric speculum. Small pediatric speculums are available. We put a speculum and open up the mucous membrane in the center and leave it. It bleeds for a few minutes, then it will close. Within half an hour, it will close. And this is how it looks like after a few months, because this one is 6 millimeters. We are getting a nice coverage. If it's a 5 millimeters, usually mucous membrane try to grow if it is thick, if it is in this shape. It is a 6 millimeters tight fit. It's a reasonably gives a good one. So the thing is, information is always available in the net, but information is not the knowledge. For knowledge, you need experience. For experience, you need a time. You need a long walk. It's a long walk. You need to do a lot of time, a decade, 2 decades. It takes a long time to get enough knowledge to design or to do or modify this process. Just typing and checking in the net with the information world, you do it, it doesn't work. Thank you very much.
That's a very, very interesting design, Dr. Reddy. Dr. Bhaskar, do you have any comments?
So, yeah. So, Dr. Reddy had discussed during AIOS time and during Keracon about this design. So, the problem with the Oro K Pro initially also was the fact that there was the thickness of the front plate was causing an air bubble to kind of sit under the contact lens, and which was responsible for the corneal thinning. They did make it a little bit better. So, compared to the previous versions of Oro K Pro, the newer versions were better. But in the Boston K Pro, the most important or vulnerable part is the junction. It's the central 3 mm area which is being punched, and the perioptic cornea. If there is something that we can do to make sure that this junction remains stable, the integrity of the K Pro becomes valid. So I've used one recently, the Oro S K Pro. Dr. J.K. Reddy had given a sample. I've used that. The assembly was pretty simple, and in fact, the plunger to push the titanium ring is actually quite nice because it gives uniform pressure and the ring doesn't flip. Otherwise, that's one of the problem when we do a regular Oro K Pro where we try to push the titanium ring, it kind of slips and it doesn't go in place. So this plunger seems to be quite effective even for a routine case.
Okay. Swapnil, you want to add something?
I just have one question, Dr. Reddy. It's an excellent innovation. Congratulations. About the MMG, you said that you open it in the center. So you overlap it on the optic plate, right? That 6 mm plate.
Yeah, we cut for most of the times it won't get necrosed because it's quite thick. It's get
I'm
vascularized
worried
by
about the overgrowth because we used to do it for type 1 K
yeah,
Pro
yeah.
and
So overgrowth is an issue. That's why they say the type 1, type 2, they put a 2.5 mm each. Initially, I had a specially made process from RK Pro with 0.6 millimeters of edge to prevent overlap. Then what we learned is 0.23 is good enough. Only thing is mucous membrane. We don't put a lot of thick mucous membrane like initial days we are doing. Now our oculoplastics chief, Dr. Shruti, she trims and makes them a little very thin, almost like a 2 millimeters thickness mucous plug.
so
This
what
one
if
is
we
holding.
create some kind of a ledge at 4 mm or 5 mm to prevent the overgrowth?
No, no, it will never. Don't worry. We did around more than 15, 20 cases we are
So
publishing.
the thinning of mucosa has one issue itself because it remains thin all the time in these eyes, and then it gives away after some times, after a few
No,
years.
no, it won't give away. What you have to do is, mucosa won't give away, won't undergo necrosis. What you have to do is, you should not release torsophy from um,
No, I'm
uh,
not talking about the
canthus to
immediate
canthus.
immediate melt. I'm talking about 5, 6, 10 years down the line. Like I have
Yes,
one K Pro type 1 K Pro under MMG. Now it has completed 11 years or 10 years somewhere. And
that's
now
good,
it has
pretty good.
started showing the melt in that mucosa. But once it
So,
starts, it's
so
very
that's,
difficult to treat. Yeah.
this is the time you have to do torsophy and leave a small
Yeah.
opening in the center.
Yeah.
We have to do, see, whatever tears you put it, they don't stay because patient's confident, you are confident, the attention will come down. No, over a period of time, you have 10 years working well. Your confidence will increase, patient confidence will increase. He won't put the drops. You also won't insist. So this is the time you have to do torsophy. Do a bilateral torsophy, leave a small opening in the center, just 3 millimeters, 4 millimeters.
Yeah, very valid points, Swapnil, and I think very well explained or put up by Dr. Reddy. I do agree that, that mucosal overgrowth is something that bothers us. Even in OKP, sometimes, like Pallavi showed, we do have patients who come up with a mucosal overgrowth. What was interesting to see the back plate. So, any reason for making it flexible? Like, why did you change the back plate?
See, the back plate, what we had initially is for unexpected reasons, we have extrusion of the back plate in one area, even both wet and dry surfaces. Usually it is the inferior, sometimes the superior. Only the back plate. Capital process will be nice, patient will have very good vision, but extruded back plate with a prosthetic membrane. That's not unusual, even I saw it. So we thought that is because of the very rigid back plate and the lid pressure putting on the process, it is tilting the entire process. Okay, you put the lid pressure, lid is pressing on the upper portion, the lower portion will be tilted and there's a constant pressure. So we thought we need to modify the back plate and make it a little bit thinner and flexible. So what I heard is surprisingly, when the Boston people also, I think they had more number of extrusions with the titanium K Pro than with the. So they are thinking of making a flexible titanium backplate, which is not possible. They have to use nitinol if you want a flexible. They are working a lot now. They want to put a flexible backplate on Boston also.
I don't think that was an experience. At least we have had more than 85 Boston type ones with the PMMA and the titanium. So we've never had this kind of experience, but I think that's something which is very individual. But really kudos to you, Dr. Reddy, for a very interesting innovation. And we are all looking forward to look at the long-term outcomes of this keratoprosthesis and hope it sees more patients.
If I could just add a word, Shweta.
Yeah.
Yeah. So even if you have a mucosa, I mean, just for people who are starting off, having a healthy mucosa doesn't preclude the underlying donor cornea from melting. We have enough cases that we have seen where the overlying mucosa looks fine or the skin looks fine when it is a type 2, but then when you open it up, you find that the donor carrier is melted. It ultimately boils down to a lot of to a significant extent to the indication for your keratoprosthesis. So if it is going to be an SJS, problems in the donor carrier is going to be an issue, whether it is a type 2 Boston K Pro or it is an LVP K Pro through the mucosa, or it is a modified type 1 through the mucosa. You will have to be careful about mucosal about corneal melts. Unlike in OKP, to a certain extent, you end up having problems in the lamina. The underlying cornea remains clear because the lamina resorptions are much more in SJS patients as compared to, say, chemical injury or other indications of the OKP. Chemical injuries have problems more with OKP. So your problems also are subject to the indication for which you do a keratoprosthesis.
Okay, I
Point
think
well taken.
yeah, we'll move on to our next speaker, Dr. Shweta Agarwal, ma'am. She's a senior consultant, cornea and ocular surface disorders from Shankar Nethralaya, Chennai. Her talk will be on challenging situations in keratoprosthesis. Over to you, ma'am.
Thank you so much, Dr. Vandana. And it's been a great session. We have seen how the journey has been. We've also seen a new innovation. And I thought let us from Shankar Nethralaya share some of these challenging situations that we have encountered in our KPRO patients in the last few months. So I'm Shweta from Shankar Nethralaya. And beginning with the first case, this is a 20-year young male who presented to us 3 months following a bilateral chemical injury following an industrial accident. One-eyed, brisk PL, he had a granuloma with an epithelialized surface. Ultrasound axial length was only 15 millimeters with a diffuse choroidal thickening. We started him on oral steroids, waited for a few months for the eye to quieten down, for the pressure to build up, and the axial length to get better, which happened in 3 months. However, the challenge now was the intraocular pressure was though normal, but it was still a little on the softer side. Obviously, he was not a candidate for a type 1 keratoprosthesis. We had to consider for a type 2. We were expecting a guarded visual prognosis because of his earlier hypotony, significant choroidal thickening that was noted earlier, but he was a young patient with and was one-eyed, so we decided to go ahead with the Boston type 2 keratoprosthesis through the lid. As we all know, the Boston type 2 keratoprosthesis is usually combined with a total pars plana vitrectomy and an AGV tube is inserted through the pars plana because the eye is closed, and we do expect these patients to develop a secondary glaucoma over a period of time. But in view of his earlier choroidal thickening and IOP being a little borderline, we deferred his glaucoma valve implant and just went ahead with the keratoprosthesis with a vitrectomy. And it's been 18 months now. He's maintaining a vision of 636 back to his jaw. Another patient, a 45-year-old case of SJS who underwent an OKP procedure elsewhere 5 years back. He had been maintaining a vision of 6.9, and he was referred to us because he had complaints of diminished vision for the last 3 weeks. There was an exposed lamina, and the ultrasound showed a retinal detachment. His vision had dropped from 6.9 to hand movements. Now, the challenge here was because of the limited view through the OKP, the ultrasound was showing a peripheral tractional RD, so managing the retinal detachment would be challenging. Now, if for the VR surgeons, we have to open up, the central opening will have to be enlarged from 3.5 to 8 millimeters for us to put a temporary keratoprosthesis. And on clinical examination, we did feel that there was some amount of inferior laminar resorption. So the preoperative plan, we kept two as buffer. The first was we remove the lamina, do the RD surgery through a temporary keratoprosthesis followed by a PK, put this lamina in the cheek for a month or so, and then replace the same OKP lamina. However, if intraop we decided if we notice some kind of significant laminar resorption, we should be ready with a KPRO swap, that is a Boston type 2 keratoprosthesis. Now, if you see, this is when the lamina was excised. We closed the opening with a 4 millimeter scleral graft, and you can see a significant laminar resorption. We went ahead with a temporary keratoprosthesis being fixed, followed by our retinal colleagues settling the retinal detachment. And since there was a significant laminar resorption, we went ahead with the Boston type 2 keratoprosthesis, which we had kept ready for this patient. And the mucosa was reflected back. So he was a Boston type 2 through the mucosa. It's been 9 months now following the RD surgery with the Boston type 2 keratoprosthesis, and he maintains a vision of 624. Moving on, this has been one of the most challenging cases. I've presented this case a couple of times earlier, but it's still very close to my heart. A 22 young lady who known case of epilepsy, who developed these severe facial burns while cooking because she just got an epileptic attack. One-eyed, right eye was PL, left eye was NPL. The ultrasound was normal in the right eye. The challenges were many. Her frontal sinus was exposed. There was significant skin loss over the forehead, contractures at the angle of mouth. There was no eyelids. In the right eye, which was her PL positive eye, she had an overhanging conjunctiva. It was a completely keratinized surface with an adherent leukoma. So now the challenges here were, first, the choice of keratoprosthesis. Because of poor oral hygiene, teeth were not very good. We decided to go ahead with the Boston type 2 keratoprosthesis. There was no lid, so it was going to be through the mucosa. And we decided to have a staged procedure. First, release of the oral contractures, followed by the oral mucosal harvest, mucous membrane graft to the bulbar surface, and later, a couple of months later, the Boston type 2 KPRO. So this is how she was day 4 after the mucous membrane graft. We've been using Bactigras for her skin dressings and the mucosal dressings. Now here what we also did was, since the mucosa needs to get vascularized and patient did not have lids, but she had a good amount of conjunctiva. So we did kind of a conjunctival hooding over the mucosa to facilitate vascularization. We kept the eye closed for 2 months so that the mucosa takes up well. And this is how she was 2 months later. The mucosa had well vascularized. And a month later, we took her up for the Boston type 2 keratoprosthesis through the mucosa, and she maintains a vision of 20 by 200. So this is how she presented to us, and few months down the line, she's self-ambulatory, managing her own activities. Moving on, a next case. This is a 40-year-old gentleman, one-eyed, again following chemical injury. No lids, severe anterior staphyloma, restricted mouth opening, and raised intraocular pressures with a brisk perception of light. So the challenges here were an anterior staphyloma with uncontrolled pressures. So we decided to take him up for a tectonic LK, did a diode CPC for the glaucoma part. And we used a mucous membrane graft to cover, because the tectonic LK needed some kind of an epithelial cover. Now, what happened was, we all know that you have an avascular cornea. The mucosa that I'm putting over is also an avascular tissue, which is a free graft. Now, this gets vascularized through the vessels which come in through all the four recti. So when we anchor this mucosal graft, we always anchor it to all the four recti muscles to provide the blood supply, and to the episclera to fix it and to provide the blood supply. Now, exactly what happened. Peripheral part of the mucosa vascularized very well, but the part which was over the avascular cornea did not. It necrosed off, got a secondary infection, which had to be excised, treated with antimicrobials, and we took him up again for a regraft with an MMG few months down the line. And this time we applied a cyanoacrylate glue over the surface. Now, post that, COVID hit. We lost the patient for 3 years, and he came back just a few months back with a vascularized keratinized mucosal graft with the pressure still a little plus minus. This time, the challenges that we had already conquered was IOP was under control. There was a tectonic graft in situ, and there was a vascularized keratinized mucosal graft. However, the challenges that we still had were the possibility of deficiency of the mucosa, because the eye would become more ectatic after we place the K-Pro, and the possibility of an AGV exposure because he definitely needed a valve. Now, this is how the patient was when we opened it up. So we did the Boston type 2 through the mucosa, and there was a deficient mucosa superiorly. So this time what we did was we went in under the eyebrow, pulled out some fibrovascular tissue from there, and tried to bridge that graft. Now, because we had a superior graft host junction or junction of two mucosal surfaces, we decided to put the tube in the inferior temporal quadrant so that we can reduce the risk of exposure. This is how he is now, 16 months post-operative with a vision of 618, maintaining a disc of 0.7. And he was always accompanied by this beautiful friend of his. But now he comes all by himself, works in a sari shop as a salesman, and takes care of himself. So yes, K-Pro surgeries have their own challenges. We do have to think about case-based surgical modifications where a pre-operative planning becomes a huge and an important aspect of a keratoprosthesis surgery. Nothing of this is possible without a team approach to help improve your outcomes. So only a good team, when come together, can give you results where the patient and the surgeon and the team is happy. This is the keratoprosthesis team at home with Varsha and Mukundan. Along with the three of us, we have our team of brilliant cornea fellows, the OT staff, nursing assistant, our glaucoma and retina colleagues, and the anesthetist. Thank you so much.
Thank you, ma'am, for that wonderful talk. Any questions from the panelists?
In fact, Dr. Shweta, all of the presentations were fantastic. And it seems that we have come a long way from, survival issues to surviving these K-Pros for decades and having good vision. And probably we have newer technologies like 3D bioprinting and all coming in would also, change the future. But here I would like to ask few things to all of you, that would you just simplify some of the post-operative care for people who are not into the tertiary care center, and these patients, because these patients travel from one place to the tertiary care center, they are operated there and they go back to their cities or town places. There are a lot of cornea people across the country, but they don't have an access to everything. So maybe each of you can just give one or two tips for post-operative care, as well as recognizing these complications early and when to handle at their level and when to refer them to the other centers.
Swapnil, you want to start? You're on mute, Swapnil.
Yeah. So that's an excellent thing you said, Dr. Paras, because that is very important. Yesterday only one of my K-Pro, which is 11-year post-op, and I got a call from Patna by one of a consultant where I referred for the follow-up. And the patient came to me last month with 6/6 vision, and she said that patient has counting finger vision, and she said what to do. So this is where it comes in picture. So I just told her that first stain the surface. Do you see any defect or any melt or kind of thing? She said no. Then I said, okay, fine, just put the parakin and do Siddle's test, as Siddle's test at the edge of the K-Pro. see, is there any leak? You see visible leak? She said, no. Then I said, okay, fine. Can you get the sonography done and send to me? She sent the sonography, and there were few echoes. And that's where I think it's very important for the surgeon who has done the K-Pro to guide the ophthalmologist who is following up. And obviously, the protocols are always written that patient has to put the antibiotics, patient has to change the BCL. Sometimes you might as well ask them to do a tarsorrhaphy temporarily and then send to you. But I think what is important is each and every K-Pro patient is different, and only that surgeon knows what that patient needs. So it's very important to guide every comprehensive ophthalmologist who is following up the patient step by step what that particular patient needs. Because like yesterday's patient was a patient with thermal injury, and I think Shweta would agree that these thermal injuries really do very, very bad compared to any other indication, compared to SJS, compared to any chemical injuries. These thermal injuries are really bad. So I think it is very important for you to guide them what to do next. Take them step by step so that you get some idea about what is going on. So
It's
that's what
very
I
important
follow.
to have a link between the referring doctor
Yeah.
and the primary surgeon. But sometimes the primary surgeon or the primary referral doctor is not the one who has referred that patient, and the patient has moved somewhere else, or they are lost for follow-up. So this is very important for everyone
So
to understand.
I just always tell my patients to keep my number, and wherever they go, ask that ophthalmologist to call me.
Yeah, I think
So they
that's
usually do that. Yeah.
Yeah, so I agree with you, Swapnil. I think that's what Dr. Pallavi, all of us have been talking that, this is a bond. Once you sign up for keratoprosthesis, all patients have your phone numbers. They all have your secretary's number. If your secretary is not reachable, you are definitely reachable, and they can just send you a WhatsApp message and then you connect with the doctor. So, in addition to all this, the point that I think Dr. Paras wants us to highlight is, in addition, the people who are attending the session today, what is the few things that from us we can tell them. So I think a detailed basic slit lamp evaluation is something that is mandatory. Any patient that comes to you, typical slit lamp examination that we do for all patients, like a history, if there is a drop in vision, what has been the duration, is there any pain, redness, watering, is there any discharge that we are seeing, is there any obvious finger tension, I think again becomes extremely important. If the FT is on the lower side, that there is for sure some leak somewhere, even if we are not able to pick it up on a Seedles, because sometimes if the eye is very hypotenuse, you won't be able to pick it up on a Seedles. So a fluorescein staining to look at if there is any epithelial defect. Ultrasound, see the fundus if you're able to see the fundus. If not, then get an ultrasound done. So I think a basic slit lamp evaluation that we do as a routine as an ophthalmologist for every patient will help us pick up most of the things. Palvi, would you like to add something?
Yes, ma'am. Like as Dr. Paras was asking, is the post-op regimen, especially in the type 1 patients, what we normally do is we always, whenever their last visit is, we give them a sheet of paper in which it is written, and in case of drop of vision, what has to be done. And as Dr. Swapnil said, I keep a separate number. I have two numbers. One number is only for my K-Pro patients. But what is more important is the antibiotic prophylaxis. And for all type 1, we also give them antifungal, which like I follow the first 5 days of a month. And every Sunday, we ask them to use this betadine. Sometimes when the patient is going to the local doctor, they are very confused. And they say that, why are you using all this? So that's where the importance of, them knowing. So the patient carries a sheet which says that this is what has to be done. And we have had a lot of glitches with the BCL. So normally in type 1 BCL, we are using is the large diameter who have a high decay value, which we change every 3 months. But some of them may be using the normal BCLs, which have to be ideally changed every month. So the importance of changing BCL and even changing of antibiotic every 3 months to prevent resistance, because you can't give one antibiotic for the patient. So I have a regimen where every 3 months I change the type of antibiotic we give. So these are a few things which we have to take care. And I think that's what I wanted to just add.
Great.
I think
Any more
one point
questions?
for SJS and all those patients would be, whenever they start complaining of watering, I
Yes.
think, yeah, sometimes they say that now my eyes watering, especially SJS patients, and that's, I think, probably the biggest red flag for all of us that something is wrong.
Yeah, great.
I think the best capro surgeon is one who loses the list, not not who does more capros, who lose the list capros.
Correct.
Very
Absolutely
true.
true. Dr. Vandana, you want
Yeah,
to?
next, I think we have 3 case presentations coming up. So we'll move on to the case presentations. The first one is by Dr. Varsha Pambani from Shankar Nethralaya, Chennai. Again, she's a cornea and ocular surface consultant from Shankar Nethralaya. So can we please have the case recordings?
Dhoni finishes off in style, a magnificent strike into the crowd, and India lifts the World Cup after 28 years. We all remember that moment, don't we? Some victories feel like the perfect ending until the story asks for more. Here, I would like to present a case of a 40-year-old male with a history of severe chemical injury, one-eyed patient, had uncontrolled IOP for which he had already undergone a diode CBC and an ML glaucoma valve surgery. He underwent MOOKP. He developed an IOP spike, requiring a second AGV along with oral acetazolamide. But he maintained a best corrected visual acuity of 6/18 for almost nearly 7 years with a cup disc ratio of 0.8. Now, he presented with an uncontrolled IOP for which topical AGMs were added and oral acetazolamide was increased. But he also presented with an increased protrusion of cylinder, which on a CT scan showed significant laminar resorption. So the concerns over here are an uncontrolled IOP, which needs an AGV tube exploration plus minus an endo-CPC, and a significant laminar resorption, which has a high possibility of leak. What are our options? First, we do a capro removal with the glaucoma intervention, but that would lead to the loss of vision. Second, we do a capro swap with the Boston type 2 along with the glaucoma intervention, but the patient was unwilling due to the financial constraints. Third, prepare another tooth and meanwhile increase the oral acetazolamide for the next 3 months. Due to the financial constraints and given the patient preference, we proceeded with the re-MOOKP, our second innings as we call it. A second lamina was fashioned and placed in the cheek for vascularization. However, 3 months later, patient presented with an active leak. So, considering the risk of hypotony following a tube exploration and an enlarged corneal opening after the capro removal, we opted for a staged approach. Tube exploration plus capro removal plus endo-CPC with a PK at a first stage, followed by a re-stage 2. Let's see how this second inning unfolded. Mucosa is reflected carefully. Any kind of pull on the cylinder is avoided. AGV areas are explored and all adhesions are released meticulously. The lamina is now dissected, taking care to avoid enlarging the opening and the sudden hypotony. The central opening is then closed with the help of a 4 mm scleral patch graft. 8 mm trephination of the host bed is done. 8.2 mm temporary keratoprosthesis is placed. Residual vitreous and the blood clots are cleared. The disc is 0.8. 180 degrees of endo-CPC is done. 8.5 mm corneal graft is sutured. Mucosa is replaced back. You can see the significant laminar resorption over here. Now, why an 8 mm Drefine was used for the host bed? Because temporary capros are available in 6.2, 7.2 and 8.2 sizes. Because the central opening of the optic cylinder is 3.5 mm and using a 6 or a 7 mm Drefine would bring in 2 graft host junctions very close in stage 2. 1 month later, stage 2 completed. 1 week later, BCVA 6/18, normal IOP and off medications. Capro surgeries present with unique challenges. They demand individualized strategies and a team approach. With meticulous planning and close follow-up, outcomes can be improved because every ending is a new beginning and because some victories are meant to happen twice. Thank you very much.
Thank you, Dr. Varsha, for the wonderful presentation. Any question from the panelists? And Shweta ma'am, would you like to add anything further to the case?
No, in fact, I would ask Varsha. Varsha, anything that, we had the last discussion about a preoperative, a slit lamp or a routine post-op follow-up visit. Anything that you would like to add on to the post-operative follow-ups that the patient comes in with?
So to add on to that, ma'am, the type 1 keratoprosthesis that we do, so we make sure that the patient comes to us for a follow-up every 3 months, because we have to do, the BCL that is put has to be replaced every 3 months. Again, as Dr. Pallavi ma'am told that the patient always is on some kind of an anti-fungal and an antibiotic prophylaxis. We ask them to put betadines also every, Saturday and Sunday. So the follow-up is more stringent with type 1 keratoprosthesis as compared to a type 2, wherein, we can have a liberty to call the patients for follow-up every 6 months. Again, at every visit, we do a complete examination, full examination of all the patients when they are coming for a follow-up. And counseling, I believe, is, chair time, giving to the patient to explain to him that what are the signs and the symptoms that he will experience and report to us or to a nearby cornea surgeon becomes the most important thing. Decrease in the vision, like Dr. Swapnil sir also told, that a watering in a patient with an SJS, it is a sign that there is a leak you will never expect. Sudden decrease in a vision. Sometimes, these patients which have 3/60, 4/60 vision, even a slight drop in a vision, like even a simple haziness of the vision, it matters to them a lot. So even sometimes you are not able to see what is going on, in what is happening wrong. But if the patient says that his vision has dropped, we should always get alerted. Again, in type 1 patients, like we do fundus examinations, fields, which are done every 6 months. So that becomes a routine follow-up regime in all these patients. So I would say that counseling, chair time, and a regular follow-up is mandatory in all such cases. And this has to be explained to the patient preoperatively before planning on to the surgery, counseling of all these conditions, that it's not that the surgery is done, but the follow-up is also more important. So patient has to understand that.
Yeah, I think
And
very summed up, Varsha. Like in this case, I think, the entire planning of this patient and us getting his second tooth ready was just because of a good post-operative evaluation. So every follow-up visit that the patient came, because there was the glaucoma person involved, and we were keeping a close watch on his lamina, that we in time were able to fashion his lamina and not have a period of where he's not able to see, because for these patients, psychologically losing vision for a few months can be significantly impacting their lives. So a good follow-up visit and a proper care is the most important part. Anything else? Otherwise, we
do
can
you
move to the next one.
you rely only on finger tension for type 1 patients? Have you tried checking the IOP over the sclera, or your
Yeah,
experience in that
so
with
we have, but they all have their own errors. So the finger tension is something that is the most reliable, but we also follow them up once in 6 months with visual fields, and at every visit, that is 3 months, we get their glaucoma OCT done and a disc photo done. So in addition to the finger tension, it is the disc evaluation, the glaucoma OCT, and the visual fields which help us manage glaucoma in these patients better.
Okay. Thank you, ma'am. I think we'll move on to the next case presentation. That will be by Dr. Gaurav Pandey, fellow from Narayana Nethralaya, Bangalore.
For many, corneal transplant can restore sight. But what happens when eye rejects every graft, or there is a very high risk for corneal transplant failure? That's when we turn to keratoprosthesis, a device offering hopes of vision when other treatment modalities have failed. But it can face its own complications like retroprosthetic membrane, donor corneal necrosis, device extrusion, and sterile melt. There are some barriers to new K-Pro implantation, being financial cost, delays in ordering and availability, and psychological impact on the patient. In resource-limited settings like many parts of the India, these become major barriers. But when the problem lies in the host tissue, not the keratoprosthesis, can we reuse the same implant safely and effectively? Let's take you into the operating room where this idea became a reality. This video demonstrates video of refurbishment of old Boston keratoprosthesis with new carrier graft in case of carrier graft melt. To begin with, we marked old cornea with Refine. An incision is made at graft host junction with the help of side port knife. The carrier graft is then carefully separated all around and peeled from the host bed as demonstrated in the video. Fibrous tissue attachment at the edges and the undersurface of back plate are cut and released all around. The K-Pro complex is gradually freed from the host bed and cleaned with povidone iodine solution. And then the retroprosthetic membrane is cleared. The next important step is disassembling the keratoprosthesis complex. And the most important step is unlocking the titanium ring. The keratoprosthesis complex is stabilized by one hand with a blunt forceps, while the other hand gradually releases the ring from the screw, thus unlocking it. This step has to be done meticulously, or else the titanium ring may snap and get deformed. Then careful separation of the front and the back plate is done. To reassemble this keratoprosthesis with the new donor cornea, first, the donor cornea is trephined and central 3 mm zone is punched full thickness. The graft is placed over the front plate, then followed by the placement of the back plate. Assembly of the keratoprosthesis is completed by locking the titanium ring. The new keratoprosthesis complex is then secured over the host cornea using interrupted 10-0 nylon sutures. Suture knots are buried and they are ensured to be watertight. Thus, instead of performing temporary tectonic keratoplasty and planning for a fresh keratoprosthesis later, we have refurbished an old one, saving time and cost. Thank you.
Very interesting case, Dr. Gaurav. I just had one question. Any particular reason that we did not consider a tectonic lamellar graft, which is routinely done for patients with a melt, rather than refurbishing the K-Pro or using a completely new graft? Because like you rightly said, there is always a problem with the titanium ring. That ring can become loose, and then refixing it can always be an issue. So any particular thoughts on that?
Firstly, I would like to thank Corneal Society of India for giving me this opportunity, and I would like to thank Dr. Yatish sir for giving me this chance to present his case. As ma'am said, in these have been performed in cases already keratoprosthesis was performed in cases where already failed graft was present.
No, I'm
So-
talking about in these patients, we normally do a lamellar patch graft.
Yes,
Like,
ma'am.
instead of replacing the entire cornea, the thinned area is covered with a lamellar graft. So any particular reason for that?
It was completely melted already, ma'am. So rather than just placing another tectonic lamellar graft over it and letting for it to undergo a failure again, we planned for a refurbishment of the K-Pro, ma'am.
Okay. Dr.
Because
Patel?
in other setups, probably the K-Pro availability and the cost effectiveness will not be good. But since we are planning for the same refurbished K-Pro, rather than charging the patient again for another Boston keratoprosthesis, so we rather plan refurbishment than a tectonic lamellar patch graft, ma'am.
Yeah, Dr. Pallavi, anything you would like to add?
Yeah, a couple of things. I remember me having done this around nearly 6-7 years back, and then I remember Dr. James Chodo saying that two aspects are there. We can have small micro fractures in the plate. So that leads to more inflammation. And second is, infection. So I don't know, those two things we have to take care. And I just wanted to know, was there a leak or only melt, doctor?
Ma'am, in these cases that were performed for the refurbishment, there were sterile melts also, and along with that necrosis as well. No leaks, ma'am, were noted per se.
Yeah, that's where probably, as like Dr. Shweta is saying, if there is no leak, I would still go ahead putting, like, how I showed in my video, lamella skirt, and cover it with the conjunctiva and give that trial rather than opening it up. And second is, I don't know, I missed a small part of your video. Did you do it in the same sitting, or you ETO'd it and then
Yes,
used it?
no, in the same sitting, ma'am. We placed the
Yeah,
betadine drops for
yeah,
5 minutes. We
yeah.
dipped it in that, and then tectonic patch, that graft was placed as a new carrier graft in the old K-Pro.
Yeah, because that's the only thing. Maybe we can do a tectonic ETO and use it later. But I have done in a case, and till now it is not having any issues. But another case where we tried to do that, we saw that when we're trying to remove the titanium ring, there are small fractures in the rings, the back plate rings. So little we have to be careful.
Yeah.
But yeah, we can do.
Good case, Dr. Gaurav. I think, Dr. Vandana, we have one
yeah.
last presentation.
Yeah, we have one last presentation that will be by Dr. Gaurav Verma, who is a cornea fellow from Shankarai Hospital, Coimbatore.
Good evening, everyone. I'm going to present a case demonstrating single-stage keratoprosthesis implantation with mucous membrane grafting. Our case is a 59-year-old male who is a known case of Stevens-Johnson syndrome and complained of diminution vision in both eyes since 5 years. He had closed face finger counting vision in the right eye and 2/60 vision in the left eye. IOP was within normal limits in both eyes. This is the slit lamp photo of the patient showing poor ocular surface with vascularization and keratinized epithelium. Patient was planned for right eye K-Pro plus MMG in a single sitting. The video is showing the surgical technique. First, the donor tissue is defined, is placed over the optical cylinder, followed by backplate, and then it is locked with a titanium ring. Host tissue trephination is done, and assembled K-Pro is sutured onto the host tissue with interrupted tenno nylon. Now, the trimmed mucous membrane graft is glued over the ocular surface and is nicely tucked under the fornices. At the end, a conformer is placed and the tarsography is done. At 3 months post-operatively, a central MMG opening is made under topical anesthesia. This is the post-op slit lamp and aososity of the patient showing K-Pro in situ with overlying healthy mucous membrane graft. At 3 months, patient had a vision of 3/60 which improved to 6/24 at 1 year and maintained a vision of 6/12 at 3-year follow-up. These are some other successful cases which underwent single-stage K-Pro with mucous membrane grafting. Retroprosthetic membrane formation, glaucoma progression, infectious endophthalmitis, mucous membrane graft necrosis, retinal detachment were some of the complications which were noted post-operatively. To conclude, single-stage K-Pro with mucous membrane graft is feasible and provides excellent anatomical and functional outcomes similar to two-stage K-Pro with MMG. Thank you.
Nice case, Dr. Gaurav. So you showed us all the successful cases. Tell us something about those cases that did not do well. So which were these cases? What were the complications that you had in these patients where you did a single stage surgery? Because normally, so the reason that they do a two-stage surgery is one, like I mentioned in my a few cases that the mucosa is a free graft that we are placing on the surface and that needs to get vascularized. And once that is vascularized, the underlying K-Pro related complications reduce, which is why you all keep the eye closed for 3 months so that it gets vascularized. So the eye is all closed. The second reason we do a staged mucous membrane graft is the small worry or concern that we all have of an infection, because how much ever sterile precautions you take, or you keep the mucosa, oral mucosa, into betadine solution for some time, or antibiotic streptomycin for some time, the oral hygiene, especially in our population or across, is definitely a thing that we are a little worried about, and we do not want to open the eye, open the globe, and do an oral mucous membrane at the same graft. So I think that is the main reason that people do a two-stage surgery. So you showed us some very beautiful cases. So tell us something about the complications that you people faced in the single stage surgery.
To answer that, I will answer because he is there with me as a fellow for a
Oh,
short
awesome.
time. We are doing for more than 15 years this one single stage. One is we don't want traumatized mucous membrane twice, opening again, cutting off all the 50% blood supply and doing. So the first time, um, as you're telling, betadine wash, we do betadine after taking mucous membrane. But the only thing is in the irrigating solution, we use vancomycin and tobramycin. That continues some antibiotic, both gram-negative, will be there in the all capable cases. Vancomycin and tobramycin in the drip will be there with the MLC levels. And we didn't have any infection. Infection is not issue. Immediate results are excellent, as your pointed out. Long-term results, yes. We had problem as Dr. Swapnil has pointed out, a watery eye, leaking. So the graft, the junction of the carrier with the prosthesis. There is coming the problem. In spite of having a thick mucous membrane, still a dry spot is forming, and a aseptic necrosis of the um, uh, donor is coming, and from there it is leaking. Thinking that we put a sclera, few cases are okay, but one case, even sclera aseptic necrosis started. We don't know why. Sclera is pretty tough when compared with the cornea. So that's why we changed now the optic to the 6 mm. We had endophthalmitis where we had to do vitrectomy, put a silicone oil, and we had at least one, two patients. We did 3 times. We exchanged 3 times. As you are telling, glaucoma is a big problem. We don't do all these problems are there. We faced it.
Yeah, great points there, Doctor.
But still, we are doing single stage only because in a good time when we are not, we used to finish it in 1 hour 45 minutes exactly single stage. That's a pretty good operating room time. Nobody will complain. Now we are a little bit slow. We are taking around 2.5 hours to 3 hours one patient single stage. But still, it is much better than the multi-stage surgery when it comes to the OR time.
Dr. Bhaskar, would you like to say something? I think Dr. Gnan also wanted to add something.
So I searched, but nobody I found anybody is doing. Only one guy is doing somewhere single stage.
This is not regarding adding, just to all the surgeons who are doing type 1 K Pro, the Oro K Pro backplate comes in two sizes, 7 and 8.5. So for adults, do you routinely choose 8.5 or you prefer 7? Because
So
Dr.
now, sir,
Reddy's model has gone to 7 mm backplates now.
so they used to make a different backplate for me, sir. Before they used to make me different backplate for me, but now the model is 7 for me standard. I'm using only model for the past 4 years, 3 years. They are supplying this model for me.
For
This
us,
model.
we are still using the 8 mm for the adults, and the pediatric alone. If we rarely do a pediatric APRO because of the outcomes and multiple other complications. So it's usually the 8 mm backplate that we have been using as the standard. I think Dr. Bhaskar is also there. Dr. Bhaskar, you have any final comments, anything that you would like to add, or?
Can you please unmute yourself?
Yeah. So, I mean, as far as the backplate is concerned, the we do feel that ideally a smaller backplate works because it's away from the angle as much as possible, because you do know that the angle zippers with the presence of the backplate there. the shift of the backplate from the PMMA to the titanium was with the idea that the angles will get preserved. It was with the idea that the retroprosthetic membrane formation will come down. But both of them have really not materialized as such. You still have almost the same incidence of glaucoma. Uh, and the reason for that is the presence of the black plate in the anterior chamber. The Boston people are now working with a smaller back plate diameter, around 5.5 as such, with the idea that it is away from the angle as much as possible, which they are calling it as mini K-Pro or Mi K-Pro. So we are still awaiting. I think they've done a couple of patients. We are still awaiting the results
I think,
of
sir,
that.
Mi K-Pro is a lamellar graft. I don't think it's a full thickness graft.
Full thickness, also one with a smaller back plate.
Okay.
So
So
it's like it's the last part goes in, but it's a smaller back plate.
Yeah, but the back
So-
plate is intralamellar, I believe.
No, it's
Yeah, so
behind.
if smaller backplate is a thing to go, what is stopping us from choosing 7 mm instead of 8 mm?
You can.
You can.
I
So-
mean, see, initially they also said they felt that a larger backplate will keep the reduce the retroprosthetic membrane. That was Professor Dolman's idea. So he wanted a larger backplate initially. Then they shifted to a smaller backplate, more from the pediatric eye, because when Dr. Akwiwala started doing pediatric K-Pros, the 8 mm would not fit into those eyes, so they made a smaller one. So they kept it as a pediatric and an adult. So with experience, you have a thought that this should work. It might work, it might not work, and you keep changing. For us, we use a 7 if the eye is pretty small for whatever reason. Otherwise, it's going to be a standard that comes, because you don't have a separate inventory of pediatric back plates. Earlier, they used to give us the option of selecting back plates. Now we don't have that option. Whatever comes with the K-Pro, we take it. And with the titanium, they don't have a 7.
Titanium is always 7.5. I think it's
7.5.
not 8.
Yes.
Yeah, they don't have a 7.
It's not 8. It's
Yeah.
7.5.
It's 7.5. 7.5. And
Titanium is also 8 only, sir.
8. Lucia is 8. Lucia is 8. Titanium type 1 is slightly lesser.
Yeah, right.
But Tony says he's always uses 7 mm. He never uses Anthony Allaway. Allaway says he always uses 7
Use
mm.
7.
He never
Yes.
uses.
Yeah. So
he never uses
yes.
8 mm. But I think 8 mm is not necessary at that time. Something. But
You
I
probably
feel the
don't
main
need.
thing is the front.
Yeah.
I feel over a period of time we can go even up to 6.57. I don't want to jump it over a 9. So I started with 6. Once you use one, and then you'll be very happy. I can assure you. It's not a just overnight thought. Over a period of 20 years, we keep on. I did at least 100 models. Out of them, this one was working well.
No, it looks a great model, Dr. Reddy, and we are all wishing you all the
Just
success.
try once. Then
Yes.
you decide.
For sure, sir. Dr. Paris, would you like to sum up the session if we don't have any more questions or comments?
There any other questions from the audience anywhere? We've answered all of them. Maybe we can just
Yeah,
I think
just
we-
one question from the chat was how many cases of Oro K-Pro S has been done and how long is the follow-up? For which
I
Dr.
think
Reddy
that
has answered.
Fogla is this new model, RMK Pro S model. That's what 3 years back we started. Simultaneously, we are doing RMK Pro and this model in selective cases because we don't want to jump up. So we did around 6 cases, and after 2 year follow-up is pretty good. So we shifted 100% now to Model S.
That's we don't have any other audience questions. Yeah.
I think we have had a great session. It was wonderful to learn from all the experts about K-Pro journey. And definitely we have come a long way from the initial cases of K-Pros to, such a long survival. At the end, I would like to thank all the faculties, the presenters who have brought in very interesting cases. The panelists who have made it very interesting discussion, and a lot of take-home points were added to the session. I believe that most of the cornea people who are not practicing K-Pro would be able to take care of their patients a little better after listening to this webinar. With this, I would also like to extend my thanks to the CSI office, back office people who have made this possible to run this smoothly. And thanks for a great moderation, Dr. Shweta and Dr. Vandana, and wonderful cases. And all, we had a good session. Thank you all, and good night.
Thank you so much.
Thank you. Thank you so much.
Thank you, Dr. Gyan, for
Good
giving me
night.
this, for being here.
Thank you.
Yeah.
Thank you so much.
Thank you.
Okay, good night.
Good night.